Hey, good morning, crew. I'm Chris, one of the pharmacists from East Bay Pharmacy. Welcome to another training session with me. Today, I'm excited to dive into a really important and sometimes challenging aspect of dementia care managing behavioral and psychological symptoms of dementia, or BPSD, especially in the residential care setting. Now, we all know that dementia is widespread, affecting over 55 million people around the world. What makes this especially relevant to us in residential care is that up to 90% of people with dementia will experience BPSD at some point. Now, that means that it touches nearly every part of dementia care that we deal with. So, it is so important that we get better at managing the symptoms so our residents can have the best quality of life possible. So, over the next 30 minutes, we're going to cover a few key things. First, we'll define what BPSD is and explore why it happens. We'll then look at the current issues in this management, especially how we often lean too heavily on medications. And after that, we'll focus on the importance of proper assessment, how we can better understand and track the symptoms. And then we'll dive into both non-pharmacological and pharmacological management strategies. And finally, we'll wrap things up with some real life case studies. Now, by the end, my hope is that you'll have some actionable takeaways to improve the care for your residents. So, what exactly is BPSD? Now, when people hear the term dementia, they usually think of, memory loss or cognitive decline. But BPSD actually refers to the non-cognitive symptoms people with dementia experience. Now, these can be a wide range of behaviors and psychological issues that aren't necessarily connected to memory or thinking skills. These behaviors can include agitation, aggression, depression, anxiety, apathy, delusions, and even hallucinations. We also see things like, restlessness, wandering, and irritability. It is important to note that these aren't examples of, acting out or bad behavior. It is often the reaction to the surroundings or when the needs are not fulfilled. Now, why does BPSD happen? This is such an important question because it helps us look beyond the behavior itself and consider what's driving it. We often talk about behavior as a form of communication, and that's especially true with dementia. Think about it like this. Imagine you were in a strange place, feeling confused, maybe even in pain or scared, and you couldn't tell the people around you what's wrong. And that's what many of our residents are experiencing. They simply can't always explain how they feel, so they show us through the behavior. For instance, someone might get aggressive because they're uncomfortable and in pain. Maybe they are frustrated because they can't find the bathroom or the room is too noisy. If we only focus on the behavior and don't try to uncover the cause, we might miss an opportunity to really help them. And this is where empathy and curiosity comes in. We have to keep asking, what's this person trying to tell me with the behavior? Now, one of the biggest challenges we face in managing BPSD is our tendency to over-rely on medication, especially antipsychotics. Now, these medications are appropriate for mental health conditions like bipolar disorder or schizophrenia, but we often use them too much too soon in dementia care. We've all seen it. A resident gets agitated or aggressive, and usually the go-to solution is medication to settle them down. But as a matter of fact, antipsychotics shouldn't be a routine alternative to things like benzodiazepines, or even worse, a way to sedate someone because they are hard to manage. The problem is that antipsychotics are only marginally effective for most BPSD symptoms and come with a lot of risk. For example, it increased mortality, strokes, falls, and cardiovascular events. While they may reduce aggression or hallucination in the short term, but they don't address the root causes, and the side effects can often outweigh the benefits. Now let's dive into the importance of assessment, which is really the foundation of effective BPSD management. Now, one of the tricky things about BPSD is that many residents with dementia struggle to communicate what's wrong, so we can't always rely on them to tell us directly. And this is where observation and solid communication between staff members are crucial. We need to keep track of when the behavior starts, how long it lasts, what seems to trigger it, and how severe it is. Using behavior charts can actually help us spot patterns over time and better understand what's going on. Now, at the same time, we need to rule out other causes. Could it be something like delirium, depression, or an underlying medical conditions, for example, a UTI, other infections, or simply untreated pain? It's also worth checking whether medications they're already on could be contributing to the behavior. So assessment is kind of like detective work, digging into what's driving the behavior so we can figure out the best way to manage it for going forward. Now, when we are assessing BPSD, we need to take a really broad view approach. There are medical, pharmacological, and environmental factors that can all contribute to these behaviors. For example, medically, things like untreated pain, infections like UTIs or pneumonia, or even sensory issues like hearing loss or vision problems can lead to agitation. These might not be obvious at first glance, but can have a huge impact on behavior. On the pharmacological front, certain medications can worsen BPSD symptoms. For instance, medications with anticholinergic effects, like some bladder control medications, which can increase confusion. Sedatives like opioids can also make things worse by contributing to confusion or falls. And finally, there is the environment to consider. Is it too noisy or crowded? Is the person feeling isolated? These factors can be the tipping point for someone who's already feeling anxious or confused. So we really have to look at the bigger picture when we are assessing BPSD. Now let's talk about non-pharmacological management, which is really where our focus should be. The foundation of managing BPSD is a patient-centered approach. It's all about getting to know the resident's personal history, likes, dislike, and what makes them comfortable, so we can actually tailor our care accordingly. For example, playing a resident's favorite music during stressful times like meal times or showering can really make a difference and significantly reduce verbal aggression. Or even engaging the residents in activities they genuinely enjoy can improve the mood and reduce apathy. Even small environmental changes like dimming the lights or reducing background noise can make a world of difference for them. There are also more structured non-pharmacological interventions like aromatherapy, which has been shown to help with agitation, or reminiscence therapy, where residents engage with memories from the past, which can be soothing for anxiety or depression. But the key to all of this is knowing the individual. We need to ask, what makes this person tick? What were the hobbies and routines before dementia? And once we understand that, we can come up with strategies that really work for them. Of course, implementing these strategies in a busy residential care place is easier said than done, right? Non-pharmacological approach takes time, effort, and a deep understanding of the resident's preference. And in places where staffing is tight and time is short, this can be a real challenge. And that's why it's so important to give staff the training and resources they need to make these strategies part of everyday care. Having regular case discussions where staff can share what's working and what's not can be really helpful. It's also really important to involve families in the process, so you can get a fuller picture of the resident and what might help. And remember, small changes can make a big difference. Even things like reducing noise, adjusting lighting, or making sure residents have access to outdoor spaces can reduce agitation and aggression. So even though non-pharmacological interventions might take more effort upfront, the long-term benefits definitely make it worthwhile. Now let's shift our focus and talk about pharmacological management. Despite we always want to start with non-drug approach, sometimes medications are necessary, and particularly when the resident's behavior poses a significant risk to themselves and others. Now the key here is using antipsychotics like risperidone, olanzapine, or quetiapine, obviously we need to use it cautiously and only when absolutely necessary. These medications can help reduce the severity of delusions, hallucinations, aggression, and agitation, but only in very specific cases where the symptoms are severe or pose a risk of harm. For other BPSD symptoms like disinhibition or wandering, antipsychotics are actually pretty useless. Plus, they have a lot of serious side effects, for example, sedation, falls, strokes, pneumonia, and even increased mortality. So when we do use them, it's actually important that we keep a close eye on side effects and review the treatment regularly. When we are talking about antipsychotics, it's crucial to remember that they should always be used as a short-term trial, never prescribed indefinitely. Ideally, if there's no improvement after about 1 to 2 weeks, we should really stop them. And even if they do work, we need to review the treatment every 3 months. And that's because BPSD symptoms can settle over time, and continuing with antipsychotics just adds unnecessary risk. And during those reviews, we are not only looking at the behavior, but also checking for any adverse effects like weight gain, blood pressure changes, and blood sugar levels. These medications can affect a lot of different systems in the body, so we need to monitor them closely. Also, long-term use should only happen in very specific cases. For example, when there are no alternative treatments, or if the consequences of stopping the medication could be worse than the side effects. But again, we always aim to eventually reduce or stop the medication once the symptoms improved. Now, even though antipsychotics are the go-to for severe cases, there are other medication options to consider when managing BPSD, even though they all come with their own pros and cons. Benzodiazepines, for example, don't have a strong evidence to support the use in BPSD. They're often associated with risks like sedation, dizziness, falls, and worsening condition. So they should only be used in acute crisis situation. Now, on the other hand, SSRIs like citalopram can be helpful in managing depression and anxiety, and they may even help with agitation. Now, for some residents, anticholinesterase inhibitors like donepezil, rivastigmine, or galantamine may improve symptoms such as apathy, delusions, and hallucinations. But keep in mind that these medications are usually less effective for managing aggression, depression, or irritability. It's really about balancing the potential benefits with the risks here, and also keeping an eye on how the resident is responding. Now let's talk about something really important, deprescribing. It is the process of tapering off medications, and is especially relevant with BPSD because these symptoms are often temporary or can fluctuate. Studies have shown that many residents taken off therapy do just as well, if not better, once the medications are stopped. And of course, it's crucial to do it really slowly and carefully unless there's been a serious side effects that requires immediate cessation. Some good reasons to consider stopping a medication include: number one, the antipsychotics may not be helping anymore. Number two, the resident's environment or circumstances have changed, or there might even be a safe alternative available. But in general, our goal should always be to minimize unnecessary medication and side effects while we optimize the physical health and condition. When it comes to the prescribing, here's how we really approach it. After about 3 months of improved symptoms, we start withdrawing the medication. Again, unless the symptoms were really severe or linked to a psychiatric disorder like bipolar or major depression. If the symptoms return, we can always restart the medication at the lowest effective dose, and then we schedule another trial withdrawal in about 3 to 6 months. But here's the key: if there's no improvement after this process, then the medication probably isn't doing much good and should be stopped anyway. Also, if we're trialing a new antipsychotics, it's important to do this sequentially, one at a time, rather than prescribing multiple antipsychotics at once. That way, we can actually see how each medication affects the resident. Now, in terms of what you can do, I mean, you guys are at the front line and play an absolutely important role in monitoring and managing patients with BPSD. Now, one of the most helpful things is keeping a detailed behavior charts. Now, these charts help us track symptoms, spot patterns, and figure out what might be triggering certain behaviors. It is also essential to prioritize non-drug approaches whenever possible. Knowing the patient's history, personality, and preferences is actually the key to come up with a more personalized care plan for them. Involving family members is also a big plus because, after all, they know the patient inside out, what they like and dislike, and often talking to them will save you loads of time rather than you trying to figure things out yourselves. And then if medications are necessary, it's so important to remember to review and monitor them regularly. Keeping an eye on any potential side effects and working closely with the prescriber will help make sure, we're always using the lowest effective dose and tapering off meds when appropriate. Now let's dive into a case to put all of this into perspective. This is Mr. B. He's 81-year-old who's been living in a high care facility for about 2 months now. He moved in after his wife passed away. She had been his primary caregiver for the past 60 years. Since coming to the facility, Mr. B has been showing a lot of symptoms we've been talking about. He's irritable, resistant to personal care, and verbally aggressive. He's also been isolating himself and doesn't seem interested in activities like bingo. I mean, to be honest, I don't actually blame him for that. To top it off, he's barely eating and his blood sugar levels were all over the show. So what do we do? First, the GP ran some tests to rule out any urgent medical causes like, infections, and we start keeping in detail behavior and food charts. We also reached out to his daughter to get more background on his personal history, and this is where we started to put the pieces together. Mr. B was very close to his wife, and after her passing, he was literally dealing with a lot of grief and depression, and probably they weren't properly addressed at the time either. And we learned that he used to love gardening and classical music, particularly Bach. Now, with all this new information about Mr. B's background, the facility staff began to understand that his behavior wasn't just random or a sign of acting out. It was actually deeply connected to his grief, the loss of his wife, and the disruption of his life's routine. His irritability could also be linked to the instability in his blood glucose level. So what did they do? They implemented non-pharmacological interventions that were more aligned with Mr. B's personal history. They started playing Bach's music in the morning before and during his showers, which really helped settle him and make the personal care routine less stressful for him and the staff. Instead of sitting at the large dining table, he was actually moved to a smaller table with only 3 others, which made mealtime less overwhelming for him. And lastly, he was encouraged to join a small gardening group, tapping into his old passion for plants and the outdoors. Now, his daughter also agreed to visit more frequently, which gave Mr. B much needed emotional support. The GP also kept a close eye on his condition and discussed the possibility of restarting his antidepressant if there's no significant improvement in the next 3 to 4 weeks. Now, this case really highlights how crucial and critical it is to take a personal-centered approach when we're dealing with or managing BPSD. Now, understanding the resident's background, routines, and preference really help the clinical staff tailor more tailor-made interventions that make a real difference in Mr. B's quality of life. Now, let's shift our focus to another case. Now, Mr. J is a 93-year-old male who was recently admitted to residential care from the hospital. Now, before his hospital stay, Mr. J was living at home. He has a history of dementia, and his medical background also includes hypertension, restless leg syndrome, and ischemic heart disease. While in the hospital, Mr. J started to show significant agitation. He was actually kicking and punching staff and became very angry. Now, to manage these behaviors, the hospital staff started him on quintiapine 25 milligrams along with PRN dose of haloperidol. So what's the challenge here? First and foremost, we need to manage his aggressive behavior to keep him and the staff safe. But at the same time, we want to use antipsychotic cautiously, only for the shortest duration and at the lowest effective dose. But we all know that over-reliance on this medication can lead to serious side effects, so we have to treat this carefully. Now, when we look at how to manage Mr. J's behavior, the first priority is always safety. Antipsychotics are an option here, but only for the shortest cost possible to mitigate any risk. And of course, they should be part of a bigger, more holistic approach. It's also vital to have a conversation with Mr. J's family. We need to make sure that they're actually on board and understand the potential risks of using antipsychotics, as well as the goal we're aiming for. Counseling and consent from families are actually essential in this case. But remember, antipsychotics shouldn't be the only tool in our toolbox. We need to combine non-pharmacological methods to help manage his behavior. And this could include, reducing environmental triggers, ensuring personal comfort, and using distraction techniques to help soothe him. This strategy works hand in hand with medication to minimize the need for higher dose or prolonged use of antipsychotics. Now, building on that, let's talk about the risk management. Mr. J has other health issues that we need to keep in mind. For example, we need to watch out for falls prevention, make sure his bowel movements are regular, and review any other medications he's on to avoid potential interaction with the antipsychotics. Monitoring is also crucial. We need to keep a close eye on Mr. J for any signs of falls, drowsiness, blood pressure fluctuation, or constipation. These side effects are common with antipsychotic use, so it's important to catch them early. If any concern arises, we must communicate with the prescriber right away so adjustment can be made. And lastly, the goal is to down titrate or reduce the antipsychotic as soon as possible, really based on how stabilized he is. And ideally, within three months, we should start looking into dropping down the dose. And this will help reduce his risk of experiencing long-term side effects also. So to wrap things up here, there are some key takeaways from both Mr. B's and Mr. J's cases. First and foremost, non-pharmacological management should always be our primary approach. In both cases, understanding the personal history and preferences allowed us to create care plans that were specifically tailored to the needs. For Mr. B, it was about incorporating music and gardening into his routine, and for Mr. J, we needed to minimize environmental triggers and ensure his comfort. However, there are times like in Mr. J's case where drug interventions are necessary. Antipsychotics can help manage severe behaviors when there is a risk to the resident or others. But we have to use them carefully. They should always be a last resort, prescribed at the lowest dose for the shortest duration possible, and regular review to determine if they still need it. In both cases, involving the family in decision making was equally important. This ensures that everyone is on the same page and understands the risks and goals of treatment. And finally, monitoring for side effects is essential. Both Mr. B and Mr. J were at risk of issues like falls, drowsiness, and blood pressure changes. And by staying on top of these symptoms and making adjustments as needed, we can improve the quality of life and reduce the risk associated with this medication. By focusing on personalized, non-pharmacological care plans and using medication wisely, we can significantly improve outcomes for our residents. As we bring today's session to a close, I want to take a moment to thank you all for sitting through this entire section. I mean, it's not easy, I know. But managing BPSD is definitely one of the more challenging aspects of dementia care. But it's also one of the most important. By prioritizing person-centered care, focusing on non-pharmacological strategies, and being mindful of the risks associated with medications, we can really make a difference in the lives of our patients. Remember, at the heart of it all, we are caring for individuals who have their own histories, preferences, and needs. By understanding the person behind the behavior and working together as a team, we can provide the best possible care. I hope you find today's session valuable and that you're leaving with a few new tools and insights that you can take back to your practice. At the end of the day, it's all about empathy, compassion, and continuing to learn. Thanks again. I would really appreciate if you can subscribe to my channel and click the like and bell icon so that YouTube can spread my content far and wide. Take care and see you next time.